In this presentation, we are going to look at the causes and manifestations of urinary retention and how to care for our patients who may be predisposed to urinary retention. So what is urinary retention? Urinary retention is the inability to empty the bladder despite the urge to void, or the accumulation of urine in the bladder because of an inability to urinate. Urinary retention is not a disease, but it is a condition that may be related to another health problem. Retention can be either acute or chronic. Acute urinary retention is the sudden inability to pass urine and is a medical emergency that requires prompt recognition and bladder drainage. With chronic urinary retention, patients are able to void, but the bladder does not empty completely. This condition develops over time and is often painless. A post-void residual urine greater than 300 milliliters found in 2 separate readings over a 6-month period indicates chronic urinary retention. Urinary retention affects both men and women. However, acute urinary retention is more common in older men as the likelihood of experiencing retention increases with age. The NIDDK estimate over a 5-year period approximately 1 in 10 men over the age of 70 and almost 1 in 3 men in their 80s will develop acute urinary retention. Retention is much less common in women. Each year, about 3 in 100,000 women develop acute urinary retention, and of those women, 1 in 5 who undergo instrumental delivery will develop postpartum urinary retention. If we look at the normal functioning of the bladder, urine passes from the kidneys through the ureters and into the bladder until the bladder reaches a capacity where the urge to void is felt. Nerve signals between the brain and bladder tell the detrusor muscle of the bladder to contract and the internal sphincter to relax, releasing urine through the bladder neck, past the external sphincter, and into the urethra. Urinary retention is caused by 2 different dysfunctions of the urinary system: bladder outlet obstruction and ineffective detrusor muscle contraction strength. Obstructive causes can be intrinsic or extrinsic. Benign prostatic hyperplasia, or BPH, is the most common obstructive cause in men. Pelvic organ prolapse is the most common cause in women. Other obstructive causes include prostatic cancer, phimosis, pelvic masses, urethral strictures, stones, and fecal impaction, all of which can prevent urine from flowing freely from the bladder. Infectious or inflammatory causes such as prostatitis or urethritis may be the result of urinary tract infection or sexually transmitted infection. Inflammation and pain associated with voiding can lead to incomplete bladder emptying. There are many medications that can lead to urinary retention. Some of the pharmacologic causes include anticholinergics, antihistamines, and sympathomimetic drugs that decrease bladder detrusor muscle contraction. Analgesic opioids decrease the sensation of bladder fullness and increase sphincter tone by inhibiting parasympathetic nerves. Anesthetics, particularly spinal anesthetics, have been shown to increase risk of urinary retention. Finally, neurologic causes. Impaired innervation of the bladder caused by spinal cord injury, stroke, diabetic neuropathy, and vaginal childbirth can impede bladder detrusor muscle contraction. Risk factors for developing urinary retention include age and sex, medical conditions such as BPH, diabetes, and hypertension, surgery, particularly joint replacement, abdominal and pelvic procedures, and prolonged use of anesthesia, and previous catheterizations or procedures invasive to the urethra, which can lead to perineal trauma and urethral stricture. Signs and symptoms of acute urinary retention include the inability to void for at least 6 hours, or a post-void residual greater than 150 milliliters after spontaneous voiding. Chronic urinary retention may present as difficulty initiating voiding or voiding with a weak stream of urine. Pain, spasm, bladder distension may be palpable in the suprapubic region, and this pain is typically relieved following drainage of the bladder. Patients may feel the urgency to void or experience feelings of distress related to the inability to void. Overflow incontinence occurs when the bladder becomes full and distended and small amounts of urine leak out. Diagnostics. A history and physical should include a complete pelvic exam, digital rectal exam, neurologic exam, and medication history to determine the presence and underlying cause of urinary retention. Labs should include serum glucose to assess glycemic control if the patient is diabetic, BUN and creatinine to monitor renal function, identification of possible electrolyte and fluid imbalance. If urine can be obtained, urinalysis for concentration and composition of urine. White blood cells may indicate infection, and hematuria may indicate renal calculi. Prostate-specific antigen, or PSA, may be used to detect changes to the prostate. Imaging options include bladder scan, ultrasound, and MRI, which can identify urinary retention and possible obstructive sources. Invasive procedures such as catheterization and cystoscopy can be used to measure the volume of urine present in the bladder. Urodynamic testing may also be performed to measure the strength of urinary flow from the bladder. Treatment for acute urinary retention should include prompt decompression and drainage of the bladder through catheterization. There is some debate as to whether indwelling or intermittent catheterization is best, so follow your physician orders. If urethrocatheterization is not possible, a suprapubic catheter may need to be placed by the physician. In some instances, surgical procedures such as TURP, urethroplasty, and bladder suspension may be performed to remove obstructive causes of retention. Pelvic floor therapy may be performed by a specialist to improve bladder functioning. Use of vaginal pessary may help promote urinary outflow in female patients with pelvic organ prolapse. Pharmacologic treatments can be used prophylactically if the patient is at risk for developing postoperative urinary retention or to treat an existing retention. Cholinergic medications stimulate the parasympathetic nervous system to promote bladder muscle contraction and sphincter relaxation, while alpha-adrenergic blocking medications block the effects of sympathetic stimulation to reduce contraction of the bladder neck and prostate, which is especially useful in patients with BPH. Antibiotics may be used to treat infections that can lead to retention or prevent infections from occurring due to invasive procedures. It's important to carefully assess the patient's current medications to determine if they may be contributing to the patient's risk of retention. Complications that may arise from long-term use of indwelling catheters and intermittent catheterizations include bladder spasms, pain, and urosepsis. In the case of delayed identification, urinary retention can lead to bladder underactivity, recurrent urinary tract infections, and prolonged bladder dysfunction. If untreated, urinary retention can cause an accumulation of urine to build up within the kidneys, leading to kidney damage and renal failure. Nursing diagnoses may include urinary retention, impaired urinary elimination, acute pain, overflow incontinence, and risk of infection. Goals of treatment should include draining the bladder, alleviating discomfort, treating the underlying cause of retention, and preventing complications. Patient outcomes include a demonstrated ability to urinate when the desire to void is perceived, urinary residual volume of less than 300 milliliters, relief from dysuria, nocturia, post-void dribbling, and voiding frequently, and the patient will remain free of urinary tract infection. Nursing interventions should include Assess and monitor the patient's vital signs, abdomen and pelvis, intake and output, and the presence of pain to determine changes to fluid volume and for signs of retention. Acute retention is an emergency, so it is important to perform catheterization and provide catheter care as indicated using strict aseptic technique. Administer medications to relieve pain, treat infection, and promote urination. Encourage ambulation and postural changes throughout the day and assist the patient to a seated position when voiding. Postoperatively, provide warm compresses to the suprapubic region and avoid fluid restriction if possible. Bladder retraining and pelvic floor muscle training may include scheduled voiding every 3 to 4 hours and collaboration with a physiotherapist specializing in pelvic floor therapy. For neurologic-related retention, the nurse may initiate teaching of self-catheterization. It's important to perform perineal hygiene to reduce skin breakdown and decrease the patient's risk of infection. Client and family teaching should include recognizing the signs and symptoms of urinary retention and UTI and reporting this to a healthcare provider. Proper medication use. Avoid consuming large amounts of fluid in one sitting, but maintain small amounts of fluid throughout the day to stay hydrated. Patients with urinary retention may be reluctant to drink for fear of being unable to void. Coffee or tea containing caffeine can help to promote urinary urgency. Taking a warm shower or bath may help the patient relax and allow urination. When voiding, sit with both feet on the floor. Valsalva or Creed maneuvers may be performed to evacuate the bladder. Voiding, then sitting, and voiding again 3 to 4 minutes later can help to promote complete bladder emptying. Personal hygiene and catheter care should be prioritized. Sanitary pads may be worn to absorb urine from overflow incontinence. The impact of urinary retention on the patient may include discomfort and stress related to repeated catheterizations, surgery, and treatment. Patients may also feel anxiety related to their bathroom routine, especially in social situations. Family members and caregivers may feel the burden of stress caused by having to learn catheter care and techniques and supporting their loved one through a hospitalization. Urinary retention can also have a financial impact on the healthcare system, as urinary retention can lead to increased length of hospital stay due to trial of void days, and additional care following hospital discharge may be required for patients who continue to require catheter care. It is important that nurses identify risk factors to minimize the incidence of urinary retention and provide thorough support and teaching to prevent complications that may arise. Thank you for watching.